Hello, I'm Dr. Bowel, and I want to welcome you to the Yodo channel where we talk about difficult health topics. We have requests periodically for certain issues, so please, if you have a question or if you have something that you'd like for us to discuss, let us know and we will prepare some information for you. So that's why I chose this particular topic today. Today we're going to talk about constipation. And sometimes I tease patients that when we go into the room that we're the team that talks about peeing and pooping and pain and prognosis, and this is one of those kind of icky topics that we're going to talk about today. Today's information is for people with any illness that are disturbed by a sluggish bowel. So to discuss constipation, we're going to go through some things and hopefully we'll move right along. I hope that you learn about your bowels and your intestines, and I hope you have a better appreciation for how much your gut does for you after hearing this. Please note, I'm not a gastroenterologist. I provide this information for you today from the viewpoint of a specialist in hospice and palliative medicine, and using information that I have from my previous experience and practice in family medicine. So just what does it mean to be constipated? Constipation is a condition that's related to the difficulty with emptying your bowels on a regular basis. Typically, less than 3 bowel movements per week is constipation. Now, everybody's got their own, personal average of what their regularity is, but that's just general rule of thumb. Stool consistency is typically hard, lumpy, or dry, and often it's painful or difficult to pass the bowel movement. There may be straining involved, and of course straining can lead to hemorrhoids and pain with or without bleeding, and this will worsen the problem because you're having discomfort in the rectum and your body doesn't want to empty your bowels and cause more pain. So you kind of get this catch-22. Colon irregularity can be very serious. It can be such a serious concern that we really want to pay attention and we want to watch for this. If we go much past about 5 days without a bowel movement, we can get into some serious problems. Constipation can certainly interfere with your daily life, and it can inhibit you and kind of prevent you from having a really good day, and it can limit your ability to enjoy your activities. So it's not okay to not have a bowel movement. Even if we're not eating, our gut still turns over its lining, and we have a little bit of waste produced every day. Sometimes 2 to 4 ounces is produced. So even if someone has not eaten in several days, which can occur at the end of life, they should still have a small amount of waste that's being discharged periodically. And we're hoping, we don't want for diarrhea, but we're hoping that that remains soft. So even if somebody's just living on ice chips, they should still have a little bit of waste that's produced, and they should have a little regular bowel movement. When a person becomes obstipated, that's like super constipated, and that's not having a bowel movement for 5 days or more. One of the things that can happen is something called toxic megacolon, and that places the person at significant risk, not only for nausea and vomiting, but actually for little micro perforations of the colon, because it's dilated so much that small amounts of bacteria can leak out into your abdomen outside of the intestine and can make you really seriously ill. Your gut is an amazing thing that can have that bacteria in it, and it doesn't make your gut sick. But your belly is different. So if that bacteria leaks out through a little tiny perforation and gets into your belly doesn't have a good way to fight it or manage it like your gut does every day without even really having to, put forth much effort. So some of the symptoms that are involved with bowel irregularity, certainly pain, bloating, and gas can occur with constipation. As the waste waits in your colon for evacuation, normal bacteria in your large colon are hard at work consuming any remaining nutrients, and their natural byproduct is gas that can be produced, and sometimes it can be pretty smelly gas. There's a lot of gas that's often being passed from patients that have trouble with constipation, and that's just a backup on the brown highway with the little bacteria producing that gas and tooting their way because they really want to have that waste get through. So nausea, feeling bloated, and the description of tight is what patients have used for me before when they're trying to describe that sensation of being constipated. So what does it take to poop? Waste, obviously, and you're hoping that it's more solid than liquid, but you don't want it hard either. You need a little bit of lubrication. You need a little bit of water or moisture. And then, of course, your gut needs that motility. Did you know that there are actually categories of constipation? People put a lot of thought into this because it's such a common problem. So broadly, there's acute constipation and chronic constipation. Chronic constipation is really common. As much as 25% of people have chronic constipation that they suffer from on a recurrent basis, and they just have to find a way to manage it. So people need to deal with it on an ongoing basis. Acute constipation is acute and recurrent. Typically about 20% of adults will have intermittent recurrent issues for one reason or another with this acute constipation. But when people reach the age of about 60 or older, that number jumps to as high as 35%. And for nursing home patients, about 50% are typically affected. Activity is typically limited for patients in the nursing home, and the activity list all surrounds around the B's with bingo, book study, birthdays, and bath time. And sometimes a bowel movement is a lot of activity for some of these people just because they have to get up, go to the bathroom, and they strain. They're not walking, they're not gardening. So that's partly their age and partly their debility, but also partly the muscle tone, not just in their skeletal muscles, but also in their intestine. Activity changes might help a younger person, but it may not make much significant difference on an ongoing basis for somebody that's older and lives in a nursing home. Another interesting fact about bowel movements and stool types is that people have put a lot of thought into the various types, and there's actually 7 descriptors for your poop. So if you want to look up something on the internet, look up the Bristol chart for your stools, and that kind of specifies and gives you little examples. There's small marbles, a caterpillar-looking kind of a lumpy log. A hot dog with some cracks is the 3rd type. The 4th type is snake-like. The 5th type would be small blobs with clear-cut edges. The 6th type would be mushy or soft, really soft consistency with maybe ragged edges, soft serve type. And then the 7th type is liquid. So, I mean, that's just kind of interesting, but when doctors talk to you about the poop, they're going to want to know what type of poop you're having and what the consistency is. And so it's not something that's common that you need to know, but if you're having constipation, they're certainly going to ask about it, and it does make it for a very interesting coffee mug. Let's spend a few minutes talking about the gut and how your gut works. From one end to the other, your gut is designed to handle food literally in its raw or cooked state. Food is chewed up and treated with chemicals and acid to help break it down, transitioning through the mouth and swallowing tube and small intestine. So the different parts of the gut look for different substances, and as it moves along, it's prepared so that your body can absorb it. Nutrients, vitamins, electrolytes, proteins, fats, and carbohydrates are all processed in different ways and in different places through your small intestine. It's truly an amazing process. For Food Network fans, Unwrapped has nothing so intricate involved. Eat your heart out, Mark Summers. The mouth and swallowing tube, your esophagus, and then your stomach are all pretty much a short distance. It's like 18 to 24 inches from your mouth down to your stomach. But your small intestine is 22 feet of small intestine. Then your colon is about 3 to 4 feet of length, and it typically kind of starts down in the bottom on the right side, and it goes up the left side kind of across the front of your back, if you will. So it's like behind your stomach, but in front of your back muscles. Down the left side makes the S-shaped curve, and it goes out. And where the small intestine meets with your large colon in that right lower quadrant, that's where your appendix is. The large colon accepts what's left of that very wet and soupy stuff that after your body has gleaned and taken most of the nutrients and vitamins out. It's just got a lot of water in it. Sometimes there's a special case of constipation. Sometimes you're told that you are really constipated and you're thinking, but I can't be constipated because I'm having nothing but liquid stool. I'm not having any solid stool. How can that be? So what happens for some people with really bad obstipation is they get so constipated that the liquid stool that's dumped into the large colon on the right side actually trickles around the hard formed stool that's packed all the way around that 3 foot of your colon and finds its way out. And so you're not removing that hard, solid waste that's in the colon. It's all that liquid stuff that's trickling around, and it can be really hard to manage that liquid stool. So you can have trouble with loss of control. So sometimes your history is going to tip that doctor off, and they may need, imaging and lab, but it may be that you're just severely constipated and you're backed up all the way around your colon. So let's talk a little bit more and consider what makes up your gut. For sure, your stomach has the acid secreting cells, and there's some muscle tissue there to help physically and mechanically break that food down into that second stage. I hope you chewed it some before you swallowed it. Your small intestine has 3 parts: the duodenum, your jejunum, and your ileum. Now the duodenum, or duodenum, depending on which part of the country you are from, but your duodenum is about 7 to 10 inches long. And that's where the food mixes up with some of the juices and liquids from the pancreas and bile from your liver to help prepare those vitamins and minerals and electrolytes to be removed in that process, kind of higher up in the colon. The middle part of your intestine is the jejunum, and that's about 8 feet long. And that's where sorting of that mixture kind of occurs, and you remove some sugars and amino acids and proteins and fats, and it comes out into your bloodstream in these little prepared packages of nutrients to head right to the liver for more processing. The third part of your small intestine is the ileum, and that's about 11 feet long. I mean, some people, these places are a little longer, and sometimes they're a little bit shorter, but that one is probably the longest part of your small intestine, and there further processing occurs as well as a really special part of the terminal ileum. Maybe it's like the last 20 inches, and that's where vitamin B12 is absorbed. And that's a really complicated process, and we won't go into that, but that terminal ileum plays a key role in your ability to absorb vitamin B12. A really cool thing about the small intestine is it went green, no pun intended, way before recycling was a thing. Your small intestine puts all this good stuff out from your pancreas and from your liver, and it gets it ready for all these next steps. All that bile acid, all those bile-containing chemicals are absorbed back into your bloodstream to go back to the liver for recycling. So the liver just reuses all that stuff. Your colon, or your large intestine, is typically 3 to 4 feet in length, and it mostly just pulls out moisture. And that's why when you got a slow moving large intestine, it can take out too much fluid because the bowel movement is going through there too slow, and your body doesn't know, hey, this is good enough, just go ahead and pass it on. If it's in there, it just keeps pulling out fluid. Missing part of that fluid is not necessarily a bad thing, but if you take out too much, that's definitely a bad thing. Your colon has loads of bacteria, and those bacteria help break down the rest of what's unabsorbed in those nutrients, typically carbs and the fiber. Plus, in the process of those bacteria doing their job, they make something called vitamin K, which helps your blood for clotting, but they also have a byproduct of making that gas. Your small intestine does have a little bit of bacteria, but certainly nothing in comparison to what's in the large colon. And the bacteria that are present in your small intestine help break down fats for absorption. You don't want an overabundance of bacteria in your small intestine. And again, that's something we're not going to get into today. But if you do have interest in that, I know a guest speaker I can probably encourage to talk with us about it. Back to trouble with pooping. Your lifestyle can certainly affect you. Stress itself, a new job, starting school, travel, shift changes, those are all really common times when somebody's going to have an issue with their bowels, and it may have to do with there's no place to go, there's no time to go, and you result in holding it. And so once you miss your bowel movement, you may be behind for that entire day. Definitely the change of activity is a really common cause, especially if there's a decrease in that activity. And then dietary changes. The choices of food, the fiber content, the amount of liquid that is consumed, the types of foods that you choose. Maybe it's a low residue diet or a high fat diet or a really concentrated dairy diet. Health concerns that contribute to a slow gut. There are problems that involve the smooth muscle because it doesn't contract like it needs to, or it impairs the squeeze of the gut and it results in that lazy colon. Sometimes connective tissue disorders are involved. Maybe there's abnormal nerve innervation of the bowel, and there are many of those. With age, there's definitely a decreased sensation to the receptors and a smaller, lesser response to that sensation of stretching, or it blunts your urge to evacuate, so you can tend to get a little bit further behind each day. There are multiple medical conditions that affect those nerves and therefore the motor function of the gut. Typically, it's things like Parkinson's, multiple sclerosis, but even strokes can affect that. So your risk of constipation, not only based on your age and activity, but many health concerns. A weak pelvic floor where your muscles in your bottom just don't have the strength anymore. Thyroid problems, diabetes, kidney problems, calcium management issues like too much calcium in your body. Delirium, where a person's in the hospital and maybe on medications or restraints. An abdominal mass, certainly, or a tumor that's restricting your bowels, whether it's inside of the intestine or it's just in the abdomen and it's just a large mass. Or previous surgeries, like adhesions that are restricting the intestines from their normal movement. And obviously, medications. You've got to remember you've got this big, long intestinal tube and it just sort of hangs in there like a sack of noodles, but it's constantly moving because it's pushing that food through there. And so if there's old scar tissue in your abdomen, the intestines may not be able to move correctly, and then they can get kind of clogged up and they can move too slow. Alrighty now, let's talk about some medications that can cause constipation. If you internet search the list of medications on your list, you are probably not going to be surprised to see that probably nearly every one lists constipation as a possible side effect. So I'm not going to go through an entire list. I'm going to talk about broad categories of medications that can cause constipation. Allergy medications, antacids with aluminum or calcium, anticholinergics such as scopolamine, that might be a patch that goes behind your ear for dizziness, or oxybutynin that somebody might take because their bladder leaks. Promethazine might be something that somebody takes for nausea and vomiting, and certainly Benadryl can. So that's a whole long list of anticholinergics, and it's not all of them for sure. Antidepressants, almost any mental health medication, anti-nausea and anti-vomiting medications for sure, anti-seizure medications, any kind of antispasmodic, regardless of what muscle group it's supposed to affect, whether it's a smooth muscle group or a skeletal muscle group, but antispasmodics can slow your bowel down too much. Medications for incontinence, Parkinson's medications, and certainly blood pressure medications, most notably diuretics that pull extra fluid off of your body because they pull too much fluid out of your colon, and then calcium channel blockers that are used for heart or used for blood pressure. Vitamins and supplements, as well as pain medications. Let's talk just a minute about pain medications, and let's learn how pain medications can cause constipation. Opioids cause constipation by acting on the mu, the mu receptor in your brain. We also have these receptors in our gut. So opioids cause that constipation because they're doing their job in your brain on that receptor, so it interferes with your perception of pain, but it also slows your gut down. Constipation from opioids occurs in over half of the patients that require to use them. We sure don't want a patient that needs their pain medications to miss it because of a constipation concern. And we don't want a patient that's taking their pain medications to wind up with another problem because they're treating their pain appropriately. It does not matter how the opioid gets into your body, whether it's you take it by pill, you get an IV, or it's a patch that's on your body. If it's in your body, getting through your circulation, it's going to affect that mu receptor the same way. Your gut motility changes, you get decreased transport of those electrolytes and fluids, and then you have this abnormal response for that urge to empty your bowels. Treating opioid constipation requires consistency and monitoring on an ongoing basis. I encourage patients to just put a calendar in your bathroom on the wall with a pen right there beside it, and when you have a bowel movement, just mark on it, SML, so if it's small, medium, or large, and you can track it. Because if you're having a small bowel movement on a regular basis, you might still be getting behind. Too much bulk, too much fiber in your diet can actually make opioid opioid-induced constipation worse because the gut motility is so slow, it sets that up even more. And that's a real problem for patients at the end of life. So we do have to be careful about the choices of medications that we use to treat opioid-induced constipation. Evaluation of your constipation, definitely you're going to meet with your physician. Talk with the nurse if you're on hospice. They're going to ask you about your bowels on a regular basis, and this is why. They want to find out what's happening and about your constipation so they can explain it. They can learn the frequency of your issue, and then they can recommend the appropriate treatment. Family history may be important for them to know, and certainly if there's any worrisome symptoms, weight loss, fatigue, rectal bleeding, black stools, narrowing of the stool or changing characteristics, and then the gauge of the stool. They'll want to know those characteristics of the bowel movement. Typical tests that they may employ could include lab work, imaging, maybe just a plain x-ray of your abdomen, certainly colonoscopy if it's an ongoing issue. There's a lot of imaging that they might consider doing. If your physician finds that you have a weak pelvic floor muscles, they might even suggest a particular kind of therapy to get involved to help you with those weak pelvic muscles. So let's talk a little bit more about treatments. First off, obey nature. If you get the call of nature, answer that call. That's the mass movement. Typically that mass movement's going to be first thing in the morning. You've been sleeping, your tummy's been asleep, your colon has been asleep, so you get up, you start moving around. A hot beverage, particularly if it contains caffeine, can make a big difference in your daily routine. If I have patients that are in a rush and they're missing their bowel movements in the morning, having that morning bowel movement is really important. They may need to get up a few minutes earlier and then have a hot cup of tea, a hot cup of coffee, hot chocolate in the morning. Something with caffeine that's warm will help wake that bowel up and help keep you regular. Certainly sufficient fluid amount, but there are diet choices that you can make, whether it's fruits or vegetables, bran-containing or fiber-containing foods and supplements. Easy does it with those, and you want to balance your water intake, or you could make a bad situation worse and you just make a smelly brick. There are certain over-the-counter herbs that you can use, flaxseed, and then sugar-free candies contain sorbitol. And that can actually stimulate your bowels depending on how much you're eating. I've actually had, patients that are taking sugar-free candies because they're avoiding sugar because of their diabetes, and then they have loose stools. There are some over-the-counter non-medical things that you might be consuming that are affecting your bowels one way or the other. There are many prescription medications that are used to treat your constipation. Bulk forming agents are not by prescription. That's a fiber containing substance that's going to help trap that water. It's going to add bulk to your diet, and it's going to help keep your stool soft. Fibercon, methylcellulose, or yoursel, which is Metamucil. Some of those can cause gas. Definitely, they are dependent upon the amount of water that you consume to keep the fluid in that fiber. A small word about small volume stools. Patients can fixate and worry needlessly on the amount of stool that they're passing. If you're not eating much, you probably won't have a large bowel movement. You're not as young as you used to be. Your diet has changed from what it used to be, so you may not have a large volume stool. Don't worry needlessly about that. Communicate with your physician about that. Osmotic laxatives, Miralax is probably the most common one, but lactulose, sorbitol are also used. Now, lactulose and sorbitol can cause gas or cramping. Mag citrate is an osmotic laxative, magnesium hydroxide. Those can be dangerous because they can elevate your magnesium level and they can drop your blood pressure. So they have some untoward effects, and we're careful about recommending mag citrate and magnesium hydroxide. Those are not medications I would advise you to take unless your physician suggests it. Stimulants stimulate the colon. They stimulate those nerves. So bisacodyl is probably one of the more common ones, and so is senna. Now, both of those could cause pain or cramping depending on how backed up you are. So your doctor's going to want to have a good history from you so they know where to start in treating that bowel movement and what's going to be the most appropriate. A stool softener such as Docusate is used to moisten the stool and keep the stool soft. There's generally not an adverse effect from Docusate, but it is just a mild stool softener. There are some newer secretagogues that are available, Linzess and another class of medication, Amitiza, and your doctor will talk with you about these if they think they're appropriate. The last group is the mu-opioid antagonists. The one that we use the most commonly for our hospice patients is the N-methyl naltrexone. And it's called Relistor is the brand name of it, and we use that for patients that have severe opioid-induced constipation. It's not commonly used because we try to prevent that from happening. If a person has significant stool burden, there are some special precautions that we take. Your treatment team is going to know how to address that to keep pain and risks to a minimum when they address your constipation. Sometimes, unfortunately, we have to remove the stool from the rectal vault before we can start from above with those medications. So now I'm going to go into a little bit more depth about the medications that we don't use very often and why. We really do try to avoid the magnesium citrate or mag citrate, and I think it's still available over the counter, but I really encourage you to not use this unless you are instructed to by your physician. We also advise to limit the amount of milk of magnesia. Long-term use of this medication is avoided because of the risks of magnesium toxicity, getting too much magnesium. Phosphosoda can result in electrolyte disturbances, and those electrolyte disturbances can be severe and sometimes even fatal. It's really dangerous for these medications to be used in somebody that has a kidney problem, that can't manage their fluids or can't manage their electrolytes. We also avoid mineral oil taken orally because it can cause a serious lung problem if somebody drinks that mineral oil and then they get sick at their stomach and they throw up. If they get a little bit of that into their lungs, it's a terrible pneumonitis that can occur. Suppositories are acceptable, but not really preferred by many people. Glycerin suppositories in particular will help draw water. There are other suppositories that will help stimulate that lower bowel to have a contraction and help evacuate. An enema can be used, and again, this is something we don't like to do very often, but it's very helpful if there's really hard or impacted stool, if it's dry waste that's blocking the rectum and they can't pass it, because that will cause that backup behind it, no pun intended. So your rectum can get sore, and then we just don't like using enemas if we don't have to. In summary, having a slow colon and suffering from constipation is all too common. It could occur randomly, but it could also be due to a serious illness. And for sure, folks with serious illness can be constipated from a known medical problem, as well as from the medications that they're using to treat their medical problem. Today's information was kind of a broad review with some specific information that I hope opens your eyes to how intricate it can be to determine the cause and to treat your constipation appropriately, and I don't want you to ignore it. We want you to have the information so that facing serious illness is a little bit less scary, and we want to help you learn how to find support. We hope that you are well and stay healthy, living each day to enjoy the highest quality of life that you can, and we want you to access the information that you need in a comfortable environment that is less frightening than maybe a physician's office or a hospital or an emergency department. We also hope that you can refer back to the information if you need to hear it again, and we appreciate you forwarding the information to friends or family that might be needing it. We like hearing from you, and we're grateful for the friends that we've made through the channel. So thank you for subscribing. Leave a comment below, or if you prefer to send us a private email, you certainly can. Our email address is in the description box below. Now that the video is mostly over, I hope you did learn something, but I also want to invite you to share your knowledge. I hope that you did not poo-poo this video, and I can tell you that it's way easier than the vomiting and nausea video. I was so sick of that one. We realize there are a lot of terrific jokes about bowel irregularity, and if you want to share one, dump it in the comment below. Bye now.